Okay, so in this session, we're going to revise bronchiectasis. If you look at your tallies, it does cover it very briefly. So what tallies does is that it explains to you the congenital and acquired causes. It lists the clinical manifestations of disease, and it talks a bit about some of the signs that are produced in the case of severity of disease. So in this session, like in our others, we're going to go through what actually causes the signs and symptoms. How are the signs and symptoms produced? We want to know the actual mechanism. We want to understand this as a step by step process. Okay. um so please feel free to ask me questions as well. So I want you guys to remember it like this. Now whenever you think of bronchiectasis, I want you to think of three words. This is how I remember it. So three, not words, in fact three phrases rather. So the three phrases are infection, chronic dilatation, and copious amounts of purulent sputum. Now, I know that sounds like a lot, but I'm going to explain to you how these phrases have come about, and you're going to understand how they are produced, so you'll be able to easily remember it. Because whenever they give you cases and they want you to find a differential, they use these words like infection, chronic dilatation, and copious amounts of purulent sputum are being produced. To break down that phrase, copious means a lot, a large volume, voluminous sputum, right? And purulent refers to sputum that is infective, it's yellow in color. And well, sputum is your mucus. So that's what we are referring to, large volumes of yellow colored infected mucus. Chronic dilatation, meaning that the airways are chronically enlarged. That's what we're referring to. And infection, we're thinking of inflammation, right? So I want you guys to keep those three phrases in mind: infection, chronic dilatation, and copious amounts of purulent sputum in mind, because now we're going to discuss the process by which this is produced. Okay. Right, let's start. So bronchiectasis is this vicious cycle of inflammation and infection, inflammation and infection. And we spoke a bit about immotile ciliary syndrome. What that actually means, immotile ciliary syndrome, is that your airways are lined by these epithelial cells that have these tiny hair-like structures projecting out of them. Those are called cilia. And the cilia, when the cilia beat, meaning that they move in a specific direction and they move together, they form this like sweeping like motion that is able to sort of sweep the mucus. Now picture this in the airway. It sweeps the mucus upwards, up, so that it can be coughed out. Now, what's going to happen if those cilia are not working, so they're unable to beat, they are still, meaning that they're not moving, or maybe one, or maybe some of them are impaired. That means only a few are working. That means that process is now inefficient. You're not having that nice sweeping motion of mucus being pushed up. And the second problem in bronchiectasis is that you have hypersecretion of mucus, and we'll come back to that. So keep that in mind. As long as you understand what we mean when we say that patients that have a genetic predisposition, or they've got a congenital defect, which is immotile ciliary syndrome, it means that these cilia are not functioning. Therefore, these people are susceptible to infection. And in order to understand that, if the cilia are not functioning and you have mucus in the airway, remember that stasis is the basis for infection. So the mere fact that you've got mucus sitting in the airway means that you are susceptible to an infection. Now, coming back, you acquire this infection, okay, and you already have that genetic predisposition, or you have a congenital problem. What's going to happen in a normal case? When you get an infection, it stimulates the inflammatory response. So in this case as well, it is stimulating the local immune response. So you're having inflammatory mediators being released. Okay, you're having inflammatory cytokines, and you have neutrophils that are being released into the airway. So what does this happen? What happens in this case, right? So these neutrophils are also able to secrete and exacerbate the whole secrete cytokines and exacerbate the whole inflammatory response. And some texts or some studies or articles do say that ironically, neutrophils do help um, organisms to actually bind to the epithelial lining. Okay, so coming back to this, you have infection, and it has stimulated this whole big inflammatory response in the airway. So what's happening is that um, you sort of having the airway, it's being clogged, right? So you're picturing it because the cilia are not working, and you're having mucus, hypersecretion of mucus by the cells, meaning loads of mucus are being secreted into the airway. Okay, so and you have the inflammatory response. So you have inflammatory mediators exacerbating the condition, and it's causing edema. Okay, we need to try and remember this. So what's going to happen is that once this infection does resolve, because the immune response is able to clear out the infection, you still have to deal with this dilatation and edema that's present in the airway. Because remember that if the infection does resolve, you still have the problem um, with mucus being trapped inside the airway. So you're still having chronic dilatation, which means that patients are susceptible to recurrent infections. So now what happens is that when the patient gets an infection again, remember now we're moving on from an acute problem to chronicity, right? So the patient acquires an infection again, and when neutrophils are actually being released by this inflammatory response, the neutrophils themselves are releasing something called so they release your cytokines, but they also release elastases and metalloproteinases. Now you know that anything that has ases in it is generally referring to something catabolic, something that's breaking down something else, right? When it has the word ase. So, what would elastase do? Elastase, we said, is secreted by the neutrophils, right, during this inflammatory response. And so it breaks down the elastin of the bronchi. And so the bronchi or the tissue, the lung tissue, is now losing its structure. That's what's happening. And it's producing this dilatation that was acute. It's now becoming a chronic problem if you think of it, because now there's no structure because you've got fibrosis, you've got ulceration, you've got edema, and now you've lost that elastin. That it's important to give the airway the ability to basically contract and to expand. So you don't have that happening anymore. um so you have loss of the structure of the lung, and therefore in the case of bronchiectasis, we say that patients, they have got chronic dilatation, but at any given time when you see when you see a patient in hospital, they are presenting because they've got an acute exacerbation of the bronchiectasis. That is why they are presenting, and a patient that has bronchiectasis, they wouldn't always. So the main symptom that they have is that they are producing copious amounts of purulent sputum. But remember that when you test that sputum, it may not always be infective, because remember that they are having recurrent episodes of infection. So it's this infection and inflammation that's happening. And as we just said, when this becomes a chronic process, you're having this elastases being released by neutrophils and the metalloproteinases. And so, over a period of years, this bronchiectasis has become a progressive condition that has destroyed the lung structure. That is what has happened. Therefore, we say that patients with bronchiectasis are producing purulent or copious amounts of sputum, because the thing is, they've got hypersecretion, therefore it's copious amounts, and it's purulent because they have got this recurrent infection, because infection inflammation over and over again. That is why. And they've got the chronic dilatation because they cannot get rid of the mucus, because they've got their cilia are not functioning well. Can you see that? They can't get rid of it because they have got this chronic inflammation that's happening in the airway. So the airway is full of edema, and uh, it's lost its structure because the elastin has now been destroyed. So it's dilated, it's chronically dilated. um yeah, so in essence, that captures what's actually happening in your lung when patients have bronchiectasis. And so in the very severe cases, they say that patients would present with cyanosis, and they would have clubbing, and they would have signs of obstructive lung diseases, right? And remember that this sputum is also foul smelling, because if you think about it logically, it's been sitting there for so long that when it actually does come up, and it's also infective, so you would expect it to have a bad smell. And remember clubbing, because it's suppurative, right? So patients in very very severe disease, um, they may have clubbing, because remember, whenever we spoke about suppurative lung conditions, we did mention bronchiectasis, empyema, and lung abscesses, right? So it's foul smelling sputum as well. Just to note, severe disease, the patient has clubbing. And obviously, if I told you that the airways are progressively being destroyed, you would expect to see cyanosis as well, patients in respiratory distress, patients showing signs of obstructive lung disease. So, all of this comes when you have an understanding and you are able to conceptualize what's actually happening in the lung. I really hope this helps to put your notes that are in tallies in perspective.